Thank you, distinguished chairpersons. Thank you, Dr. Kapil Sharma sir, and the organizing team of Adipam for giving me this opportunity. Now let's go ahead with the clinical scenario and bisect what's been given to us. So we have a 65-year-old diabetic gentleman with an established atherosclerotic cardiovascular disease. And he's had an event about 9 months ago, had two deaths to LAD, following which he had a recurrence of event and had another death to proximal RCA. This gentleman is on Rosuvastatin 40 and his labs show us an LDL of 65 milligrams per deciliter, triglyceride 255, HDL 35, and LP little a 18. Now, on Rosuvastatin 40, he developed some muscle symptoms, has a myalgia. However, the labs show a normal total CPK and LDH. So first, let's examine this aspect. Now, considering that he's on a high-intensity statin and still has a recurrence of event, would you consider lowering the dose of rosuvastatin in this individual, thinking that probably he has a statin-associated muscle symptom? I have a normal CPK total and LDH. My first bet would be to encourage him to continue the same dose of high-intensity statin. Second, before rendering him a probable victim of a high-intensity statin, we must also take into consideration whether he has had any recent history of high strenuous exercise, what kind of vitamin D is he living with, and how is his thyroid status. Yet everything turns out to be normal. This gentleman probably has a nocebo effect. Just like placebo says I'm going to please, nocebo says I will harm. It's more of a subjective feeling, especially when these individuals have been educated about the possible side effects of high-intensity statin therapy. Now let's understand what kind of LDL lowering are we looking at in this individual. He's had two deaths to LAD 9 months ago. Within 1 year, he has a recurrence of event. So he certainly falls in the extreme high-risk category and requires intense lowering of LDL cholesterol, which should be lower than 40 milligrams per deciliter, as you can see in the left corner down. However, would you consider reducing rosuvastatin in this individual? If yes, would a non-statin lipid lowering therapy help? Now, be very mindful that a Rosuvas 40 or a 20 both continue to be a high-intensity statin, and the magnitude of reduction that we are looking at in this individual who already has an LDL of 65 is still high. We want his LDL lower than 40 milligrams per deciliter. So let's see what do the guidelines recommend. In monotherapies, high-intensity statins can bring about a reduction in LDL by about 50%. And with every doubling, you will have an additional 6% lowering. With the first exposure, almost about 30%. If you add an ezetimibe, you are looking at an additional lowering of almost about 60%, about 21 to 27%. And that's what the guidelines recommend. Non-statin therapies with proven cardiovascular benefit, either alone or in combination, are recommended for patients who are either intolerant to statin or who probably are being given because of additional lowering of LDL cholesterol and have a residual risk. And this was well back in the Improve Item trial, which showed that individuals who had an ACS in the last 10 days had an LDL of about 50 to 125 on the ones who were on statin 9 patients and 50 to 100 on ones who were on statin therapy. Adding ezetimibe to statin had an absolute risk reduction of 2% in the combination group, and these individuals had 170 fewer events. Now, if we were to look at the safety endpoints and the side effects, either the muscle symptoms or the elevation in the transaminase levels, they were absolutely comparable. So it's factual to reiterate that adding ezetimibe even as a monotherapy or in combination is not going to raise the CPK levels more than what is done by statins. Besides, this also showed that lowering LDL by adding a non-statin lipid lowering therapy such as ezetimibe can reduce the cardiovascular events in future, thereby offsetting the hypothesis that only statins work. So the next question is it more effective than adding fibrates in this scenario? The contemporary trials and meta-analysis of RCTs have shown that fibrates do bring about a reduction in triglyceride. But do they translate into meaningful cardiovascular outcomes? No. And this was shown in the ACCORD study as well as the prominent trial where the agents were fenofibrate and hemofibrate, and despite the reduction in triglyceride by 16% and 27%, no meaningful cardiovascular outcome benefit was drawn. So we need to look at an agent which has a modest effect on triglycerides and also has a good effect in the reduction of cardiovascular events. So one bet could be adding icosapent in these individuals, and we can see that the trials have shown almost about a 25% reduction in the major cardiovascular events. However, this individual also has an Lp(a) of more than 80. And we all know that once the Lp(a) goes beyond 50, there is an absolutely increasing risk of cardiovascular disease in log linear fashion. So this gentleman needs intensive lowering of LDL cholesterol with no upfront therapies for Lp(a). We would rather suggest a more intense lowering of LDL, number one. Number two, when we bring the LDL lower than 35, it's likely to offset the risk posed by elevated Lpa. And we must also understand that we still do not have a clinical endpoint or a cutoff below which the Lpa becomes safe. Inclisiran would be ideal as an NDRA, but we must remember that it will be an add-on therapy and not a replacement therapy. Thank you.
It's time for Dr. Jay Shah to step up the dais to talk on two questions. That is, can I reduce the dose of statin while letting it? And would triple drug combination of lower dose of Rosuvastatin, Ezetemibe, and Bempedoic acid be more effective and warranted here? Over to Dr. Jay Shah.
Next slide. Actually, I joined Dr. Kamal Karma's team for all these scientific scenarios. And I tell you, Dr. Kamal has been very difficult taskmaster all the time. In 2019, he just phoned me and told me, would you talk about Ezetemibe? At that time, it was very difficult to depend on Ezetimibe in 2019. And then I delivered a talk on Apna Time Aega with Ezetimibe. So now I have to defend another difficult task, and that is Bempedoic acid. So let me go ahead with Bempedoic acid discussion. My patient is for secondary prevention. Obviously, secondary prevention, high risk, diabetes mellitus, recurrent cardiovascular event, and patient is already not on target LDL. Dr. Kabir has already narrated very nicely what are our targets in this case, because this case has a lipoprotein A very high. And Dr. Anish will be talking about lipoprotein A and the novel therapeutic options. So we'll go into details. There may be a repetition of slides I tell you, but this patient goes for the extreme risk, and we need to go below 40. And Dr. Kabir has identified less than 35 LDL levels. So how to achieve that? Obviously, 40 milligram of Rosuvastatin in this case is not going to help. It has not worked for that. And further, patient is having myalgia. We are toying with the idea whether that myalgia is secondary to statin or not. We have obviously narrated that this type of myalgia with normal CKM is not likely to be statin induced. But then also we are worried about, we don't want to step up the dose of Rosuvastatin. Then what are the other alternatives? The first alternative, and probably the most viable alternative, has been discussed by Dr. Kabir. I will just add on to Bempedoic acid. Why to add that one? It was just one step ahead of, just one step prior to the action of HMG co-reductase enzyme inhibitors. So how to go ahead with that? Bempedoic acid usually induces modest reduction. By modest reduction, I would say that 23% reduction. And so then Bempedoic acid has to be combined with Ezetimibe, and then the reduction increases by 38%. But still we are not happy because we have high intensity statin and it has led to 50% reduction in the LDL goal. Still patient is not at LDL goal. So what are our the options? We have one option that statin plus bempedoic acid. In this case, myalgia most probably is not arising from statin-induced myopathy. That's why we preserve the same dose. We don't reduce the dose of rosuvastatin, and then we add the bempedoic acid, and the reduction will be expected to be little higher than high-intensity statin. Look at the difference. Difference is only minor 5 to 8%. And the same slide, sorry for the poor quality of slide, the bempedoic acid. There are some drawbacks with bempedoic acid. It starts working over several weeks, maybe 4 to 12 weeks. There is no consistent or clinically meaningful effect on lipoprotein A, and that's why Dr. Anish has to talk about this thing. Then we have to be very cautious. We are using high intensity statin as well as bempedoic acid. Both are working in the liver cells. And if your liver impairment is there, we have to be very cautious. May have to reduce the dose. And then again, ezetimibe comes into play. 4 years outcome of clear trial has very clearly shown. But very advantageous is that there is a lower cost. Bempedoic acid is, as compared to Inclisiran or PCSK9 inhibitor, is really cheaper variety, and that's why probably I would recommend bempedoic acid. And let me tell you that when it is alone used, moderate LDL reduction. These two are very important things. High dose statin and bempedoic acid, most probably 58%. Then we have all three together. You know, this is an era of Operation Sindoor where we have all three forces working in the coordination. Here the three forces are high statin, ezetimibe, and bempedoic acid, and we get the result of Operation Sindoor here, 68%. Triple therapy, LDL reduction is expected to be in the range of 35 or 40 LDL goal. That's my recommendation. Thank you.
Over to Dr. Anish Chandarana for something on Inclisiran, and I think we have a battery of questions which he will address, like impact and reaching the target and stepwise or combination therapy and changing the treatment paradigm. Over to Dr. Anish.
So once again, good morning to everyone, and huge compliments and praise for Dr. Kamal and the team for putting up every year such a nice, successful conference. So the previous two speakers have spoken extremely well on how to deal with lipid profile in a patient who has got extremely high risk. And they have made the job easier as the flow goes on. So we need to understand the patient, as has been well said. He's a little middle-aged plus gentleman, diabetes, had unstable angina with 2 drug-eluting stent PCI, and with 40 milligram Rosuvastatin and maintaining LDL of 65, he had appearance of new lesion to a very serious extent. He became ischemic, he had TMT positive, and he needed PCI. So now we have to, under this context, has to understand. Triglyceride is 255, so though total cholesterol is not given here, but I'm very sure his non-HDL cholesterol is pretty high. His lipoprotein is sky high, 80 milligram, which is a specific risk factor for Indians. So this gentleman is not having only extremely high risk of death, MI, and stroke, but also has got very severe residual risk because of which he will keep on getting events. So that's why whatever weapon we have to address his risk under the sky, we have to use. There is no debate between statin, ezetimibe, Bempedoic, or Inclisiran or other treatment. We have to use everything possible because unless you do that, this gentleman is going to die. I'm surprised why, in spite of the fact of diabetes and lipoprotein at 80, he has not even. Every time he is presented with angina and TMT positivity, but luckily he has escaped even. Otherwise, with diabetes and 80 lipoprotein, you will hardly find somebody reaching 60 without event. It's very, very impossible. So let me explain 4 important points. I'm very sure you are going to agree to all of the speakers. Number 1, lipoprotein A is highly atherogenic. extremely inflammatory molecule which adversely affects the plaque morphology. So it's a risk multiplier. If you calculate your risk by any method, whether ASCVD, whether SCORE, whether in Indian guidelines, which I personally use, whatever risk you calculate for a person, if his LDL lipoprotein is 80, it has to be multiplied by 2.5 to 3 times. So it's a risk multiplier. Just to cut the story short, lipoprotein drives plaque progression and vulnerability. Once lipoprotein is high, your plaques are going to be vulnerable. This is what wonderful view, color coded. Now, these are the patients who have LDL less than 60, guideline-based treated, and their CT angiography was done, and these are vulnerable plaques, low attenuation plaque. So within 1 year, in spite of the GDMT, the volume and the number of vulnerable plaque increased significantly. So lipoprotein A is a dangerous molecule. Unfortunately, at the moment, we do not have any treatment to reduce lipoprotein A meaningfully. Within next 2 to 3 years, they will be there. But till we do not have treatment, our goal is to reduce LDL to 30 or 40 in such people who are having high risk. Second point, it's very important to risk categorize every individual who comes to you. And for that, let's start using Lipid Association of India guidelines. I have stopped using American and European guidelines because they predict very low risk in our patients. They do not indicate a lot of things. So what I do is always I go to Lipid Association of India, which is extremely good. All of us who did that. Now, as for this patient who has got multiple stents, who has got diabetes and has got lipoprotein A, he is put under extreme risk category 2. And our lipid association is given what are the targets you have to achieve for people who have got different kinds of risks. So say, for example, if this gentleman who has got atherosclerotic cardiovascular disease, multiple stents, diabetes and lipoprotein A 80, his overall risk is extreme category B. If you look here, so extreme risk category B, so that's where LDL as a primary target has to go to less than 30. The non-HDL cholesterol has to go to less than 60 and ApoB has to go to less than 50. So we all need to have strong conviction for what Lipid Association of India does and what guidelines they throw. Because still I keep on chasing European and American guidelines. I'm pretty sure I'm going to undertreat my patients. Those guidelines are for the people who are 40 plus, and in India we are getting heart attack at 25, 30, 35. So we have to understand that these are our targets, less than 30, not less than 50. This slide has been shown by everyone. So a gentleman who has been on 40 milligram Rosuvastatin with LDL of 65, if you have to reach to 30 or less than that, only one thing is you have to use O4. Statin, Ezetimibe, Bempedoic acid, and PCSK9 treatment, which are two. One is Ezetimibe and second is Inclisiran. But because of the cost, because of the less number of injections, I do prefer Inclisiran. So this gentleman has to be on everything. Coming to point of Inclisiran, a wonderful treatment. It reduces LDL cholesterol by 50% and maintains it forever. So once you keep on taking Inclisiran, first injection today, second after 3 months, and then every 6 months, most of the patients are going to reduce their LDL cholesterol by more than 50%. A very important point, it also reduces ApoB, triglyceride, non-HDL cholesterol. It does reduce to some extent lipoprotein A. So all PCSK9 based therapy, maybe Ezetimibe or Inclisiran, they do reduce lipoprotein A by 20%, but mind well, that's not the base of their efficacy. And we should not use these two molecules because they are reducing lipoprotein A. To have any meaningful impact on cardiovascular event reduction, you need to reduce lipoprotein A by 90%. So somebody who has got LP of 80 has to go down to less than 10 to have meaningful impact. And those treatments are under evaluation. Maybe in 2 to 3 years we'll get there. So I'm quite fond of PCSK9 based therapy in Inclisiran, but I will not recommend to use it for lipoprotein. It is to be used for reduction of LDL cholesterol. So what about CV outcome benefits? At the moment, there is no single trial with Inclisiran which has said that there is CV benefits. But if you put 3 trials together, they all have small trials, 1,000, 1,200 patients. So if you put these 3 trials together, the data was published in European Heart Journal, that if you put them together, 3,600 patients, there was meaningful, significant p-value, 26% reduction in primary composite endpoint. Now, since they were the 3 trials put together, it should not be taken as a primary endpoint, but it should be considered as an exploratory outcome. So we all can trust that Inclisiran is going to reduce cardiovascular events if you give them. The strong data will be released within some time. Now, a very important point, when you think of LDL less than 30, statin, Ezetimibe, and Bempedoic acid have to be there. But generally in the patient which we are discussing, these three will be insufficient to take him to 30. Yes, if you have to take a patient to 55, 60, 65, these three will be okay LDL level. But when you seriously target LDL of less than 30, you need everything. A very new strategy which has evolved and which I personally use, that every patient who comes and get admitted for acute coronary syndrome gets maybe 1 to 3 multiple stents, sometimes complex lesions, left main bifurcation. So upfront, in addition to this treatment before discharge, I give the first sort of Inclisiran. So give a statin, Ezetimibe, Bempedoic acid, everything, and then give a sort of Inclisiran. And many times it is also covered in insurance. That's something which is so good. 2 doses are covered. So what we want post ACS is robust, extremely fast, lowest possible LDL to prevent next event. So if you get LDL to 10, 15, maybe even single digit, initial 3 months, it's so good for the patient not to have recurrent event. So my strategy, which has been quite very well documented in JEC also, that in a patient whom you consider high risk, straight away go with all the 4 drugs. So ladies and gentlemen, coming to sort of conclusions, what we look forward is, today we are talking about 1 pill or 2 pill a day, so maybe 700 to 1,000 tablets a year. From that, there was Ezetimibe, which took us to 24 to 26 injections per year. And now we have a treatment, just 2 injections a year. Obviously, we are not going to omit the oral medicines, but by taking 2 injections, you can be reasonably getting TIR. What is TIR? Time in range. When you talk about sugar control, what has been discussed is how long and for how many days your sugar is within range. That's where your diabetic complications are decided. So if you can keep LDL cholesterol of such a high risk patient to less than 30 forever, they are going to have less and less events. So that's where science is going. So sort of coming to conclusion of all the 3 speakers which we did carry on message, in this patient we need to have high intensity statin, Ezetimibe, Bempedoic acid, maybe you add icosapent ethyl because they've got high triglyceride, no need of phenofibrates. This patient we should get HSCRP done. We can think of colchicine also because he has got some high level of inflammation, and the day lipid treatment will come, this patient has to receive that. Inclisiran by that time is a game changer. So ladies and gentlemen, LDL cholesterol is a vascular poison, and only safe level of vascular poison has to be close to 0. I personally believe that. Reducing LDL cholesterol by any means, maybe lifestyle or any medicines, does reduce your cardiovascular risk. Desired level of LDL cholesterol in every high-risk person has to be 30, not 60, 55. It has to be less than 30. That's where you make more and more people happy. And that will require use of multiple medicines. You as a physician need to adapt the art to talk to your patient and how to convince them for multiple medicines, because to improve their future, you have to do this. And as I discussed, Inclisiran is a game changer therapy. Just 2 sorts of injections will help your patient to remain under 30. Thank you very much for listening to me carefully. Maybe I think